Thrombolytics, also called fibrinolytics, are medications that break up blood clots formed during hemostasis, where hemo means blood and stasis means to halt or stop. Hemostasis is divided into primary hemostasis, which involves the formation of a platelet plug at the site of an injured blood vessel, and secondary hemostasis, which involves multiple coagulation factors working together to form a fibrin mesh to stabilize the platelet plug. Together, these two processes create a blood clot, which stops the bleeding. Sometimes, though, blood clots could cause problems, like when they form in a coronary artery to cause a heart attack, or when they break off and travel to the brain and cause a stroke. In these instances, we can use thrombolytics to break up the clot and restore blood flow. Thrombolytic medications were actually derived physiologically from what's known as the fibrinolytic system. Approximately 2 days after an injury happens to a blood vessel and the blood clot forms, it's time for the body to dissolve the blood clot through a process called fibrinolysis, which is the gradual degradation of the fibrin mesh. To do this, a circulating protein produced by the liver called plasminogen gets converted by an enzyme called tissue plasminogen activator, or TPA, into its active form called plasmin. Normally, healthy endothelial cells release only tiny amounts of TPA, but when they're exposed to coagulation factors produced during secondary hemostasis, factor Xa and thrombin in particular, they start making lots of TPA. But it's important that plasmin activity doesn't get out of hand either. So the endothelial cells also release plasminogen activator inhibitor 1, as well as antiplasmin, which are proteins that bind and sequester TPA and plasmin, respectively. It's all about always reaching that Zen balance of coagulation and anticoagulation. Now, during an injury, more coagulation factors get activated, which causes more TPA to get released by the endothelial cells, and more plasminogen gets converted to plasmin. Plasmin then acts as a protease and cuts the fibrin into smaller pieces, allowing the trapped red blood cells and platelets to float away, letting the clot dissolve. Now, although TPA is the main activator of plasmin, a few other proteins activate plasmin as well, including coagulation factors 9A, 12A, kallikrein, and protein C. Medicine has also taken advantage of TPA, using it clinically as a clot buster, but it's used to dissolve pathological blood clots. Now, common thrombolytics derived from TPA include alteplase, reteplase, and tenecteplase. Streptokinase is derived from beta hemolytic bacteria proteins, with a similar mechanism of action. All thrombolytics are given via IV. Alteplase, reteplase, and tenecteplase work by binding directly to fibrin proteins on the clot. Next, they bind to nearby fibrin-bound plasminogen, converting it to plasmin, which then cuts up the fibrin mesh. Of these medications, tenecteplase has the highest affinity for fibrin, is resistant to plasminogen activator inhibitor 1, and has a longer half-life. In contrast, streptokinase works by binding to either circulating or fibrin-bound plasminogen. This creates a plasminogen-streptokinase complex that converts other plasminogen to plasmin, which then degrades the fibrin mesh. The thrombolytics derived from TPA are used more frequently than streptokinase, because they're clot-specific, meaning they do not cause fibrinolysis and unnecessary bleeding outside of the area of the clot, unlike streptokinase. Since these medications activate fibrinolysis and destroy clots while they're forming, they increase the bleeding time, the PT or prothrombin time, and the PTT or prothromboplastine time. However, the platelet count will remain unchanged. Thrombolytics are used for the short-term emergency management of pathological thrombosis. They're used to break up clots during myocardial infarctions, deep vein thrombosis, pulmonary embolisms, and ischemic strokes. For strokes, it's important to first rule out hemorrhagic strokes with a CT scan. These strokes are caused by bleeding from damaged arteries, and thrombolytics will make them worse. The key to using these medications is early administration. For example, it's recommended that if a person suffers a myocardial infarction due to a blood clot in a cardiac vessel, the person should be given thrombolytics within 12 hours from symptom onset. If a person suffers a stroke, they should be given the medication within 3 to 4.5 hours from symptom onset. This is because after a certain number of hours, the tissue that's supplied by the blood vessel dies from the lack of oxygen, so reperfusion won't help the necrotic tissue. In terms of toxicity, both the recombinant forms of TPA and streptokinase can cause unnecessary bleeding. Thus, they should never be administered when a person has active internal bleeding, before major surgeries, after recent trauma, or in people with a history of intracranial bleeding, bleeding disorders, or severe hypertension. Thankfully, two antidotes exist to combat this problem, called aminocaproic acid and tranexamic acid. Aminocaproic acid works by binding to TPA derivatives, and tranexamic acid binds to plasminogen and prevents its activation. If these medications fail, other transfusion products can be administered, like platelets or coagulation factors, in the form of fresh frozen plasma. Next, streptokinase is found in bacteria, so it's immunogenic, meaning it could trigger an immune response. Thus, it can cause severe hypersensitivity reactions like anaphylaxis when given. Also, our antibodies can bind to and disable them, which limits their effect after multiple uses. Finally, thrombolytics, as they reopen a clotted blood vessel, can precipitate an abnormal cardiac rhythm, or a reperfusion arrhythmia, which is usually benign. Alright, as a quick recap, the thrombolytic medications alteplase, retaplase, tenecteplase, and streptokinase work by converting plasminogen to plasmin to degrade the fibrin mesh. They're given for the acute management of pathological blood clots. Their primary adverse effect is bleeding, for which aminocaproic acid or tranexamic acid can be given.